Well, hello and welcome to Community Forum. My name is Roy Cohen and I'll be hosting today's show, which I think you'll find very interesting and kind of necessary when you're talking the subject of hospice. With us we have Michael Cruza. He's the Director of Business Development at Old Colony Hospice and Palliative Care. He's also a certified dementia practitioner and the Dementia Program Director at Old Colony. He's worked in the healthcare industry for over 27 years, specializing in hospice and palliative care for the last 15 years. At Old Colony Hospice, Mike speaks with patients, families, and healthcare providers to educate and spread the word about hospice, palliative care, and about making well-informed healthcare decisions. Mike's an alumni of Bridgewater Raynham High School and received his bachelor's degree from Quinnipiac University. And he and his family both all live in Plymouth, Massachusetts. And we welcome you to the show, Mike.
Thanks for having me.
My pleasure. I'm sure that these are subjects that people pretty much avoid, but it's necessary to talk about them.
Absolutely.
Because we all have an ending.
Mm-hmm.
And sometimes it's easy and sometimes it's not easy, and I'm sure you've got your work cut out for you when you're dealing with patients. Let's start off by an explanation of what is hospice, and when someone elects hospice, what are they getting?
Well, when we talk about hospice, it's really for those folks who've got progressive advanced disease to the point where going to the hospital or getting treatments for those diseases is causing more problems than they're solving. So somebody who has a disease where the doctor says, well, there's nothing more we can do for you, but then they don't go on to say, well, there is a lot more we can do to help you with comfort, quality of life, and dignity for as long as you're here. So we've been in the hospice community trying to educate physicians around, yes, there's no more that medical science can do to treat your disease, but there's a lot more we can do to assure that you are comfortable for the rest of your life. And that's what hospice does, is we take care of all of the pain and symptom management so that people stay out of the hospital. A lot of times we actually do tell people in the community that the hospital is no place for sick people. And if you don't need to be in the hospital and you can stay at home where you're comfortable, you might as well do that. So hospice is the way to assure that while you do have those advanced progressive disease, that you can stay at home and be comfortable, maintain your dignity, and not have to go through futile treatment that's not going to really benefit you, and really just focus on the amount of time you have left, making it the absolute best. And that's what hospice does.
Mm-hmm. So basically what you're saying is that when you run out of possible treatments, mm-hmm. The doctors will explain to you that really the next thing for you is seek treatment, but you can do it at your house using the hospice.
Yeah, I mean, that's what we do. I mean, there's a whole team that we'll probably get into in a bit that address all of those things. Mm-hmm. And where you usually think of a healthcare provider being someone who just treats a person and what's going on with them, what ails them, the hospice team actually approaches that person, but also their entire family. Mm-hmm. So hospice isn't just for the person and what's going on with them. It's for the person and it's what's going on with them, but it's also the social things that happen. What are the loose ends we need to tie up? What are old family rifts that we need to repair? Mm-hmm. There's also a component that's a spiritual component as well, where a lot of the things that come up around, what will happen to me, what happens to my family, where do I go? There's a lot of questions that come up.
Sure.
And those questions come up, yes, for the patients that we treat, but also for the family members who are going on the journey as well. Mm-hmm. So they're there to support the entire family through the process.
Why are people afraid of the H word, of hospice? Is it because they recognize that it's the end and
right.
they don't want it to be the end? I mean, it's got to be a tough decision.
It is. If we could change the H word, the hospice word, to the best possible care you need that you didn't know you needed when you need it, we could change it, but it's kind of long and lengthy and Medicare doesn't reimburse for that. So it's tough because that word just carries such weight with it. Mm-hmm. But when you start to get around the myth where people say, well, if they go into hospice, that means they're going to die. Well, we're all going to get there. It's just whether or not we want to make sure that we're comfortable, that we're surrounded by family, and that we're not worried so much. That's what hospice is able to do, because none of us are, getting off of this earth alive, and we're all going to go at some point. And so it's up to us to decide on whether or not we're going to go in the hospital with tubes, or if we're going to go at home with our pets on our laps, surrounded by family, listening to the music that we've grown up and loved. Mm-hmm. And so there's been a shift in the time that I've been doing this. A lot more people are coming around to, how do I stay out of the hospital? How do I stay home and make sure that I'm as comfortable as possible? But there's still some stigma around that hospice word. And so that's part of my charge in the community, is to tell anybody really who will listen. But it's mostly healthcare providers that I advise them on how do we approach those subjects with family so that hospice word doesn't come off as someone's dying. I assure you, we don't take care of anybody who has passed. We only take care of the living. 100% of our patients that we have on our services are alive. And we make sure that they're living their best life they possibly can while they're with us.
Do you find that when it's decision time, do you find that some of your patients will resist hospice care? I don't know why they would do that, but do you find that's the case?
I think sometimes we get families who don't come to terms with it. I've even had people in my family who, when my dad was going through this whole thing, he would say to me they just wanted to go home, but one of my siblings wanted to make sure that he saw the oncologist one last time. And even when we got the oncologist and my father was there on a stretcher, because he couldn't even get into the oncologist in a wheelchair or on his own accord, the oncologist was basically saying, no, you go home and take care of things. And sometimes family members need to have that official doctor say, there's nothing more that I can do. Go take care of yourself. So a lot of times it's other family members that are more resistant than the actual patients themselves, because the patients know what's going on inside them and they understand it more than I think a lot of family members know, but they want to be brave and fight for those family members, even sometimes at the cost of their quality of life. Mm-hmm. Yeah.
Sometimes I hear the people that are receiving the care, they kind of just throw in the towel. They say, that's enough.
Yeah. There are people who get there, and they say, I've had this third and fourth experimental treatment. I know how uncomfortable it makes me, and I'm not willing to give my quality of life up just to get an extra week or a day. And there's actually studies that came out not too long ago that will actually tell you that people who do actually access hospice, on average, live longer than those who actually don't get hospice services. And that's because they're staying out of the hospital, they're not contracting extra infections, and they're at home where they're more comfortable and surrounded by things, so they're less stressed.
Are they getting medication?
Mm-hmm. All the while. Everything that they need.
Everything they need to make it comfortable.
Yeah.
And prolong life?
Well, typically that's what happens. Once someone's comfortable, they stick around a little bit longer.
They fight harder?
No, but they're just more comfortable, so they don't have to fight. When you fight, that's a lot of stress when you're fighting.
Sure.
So to allow somebody to relax and not have to be anxious and woken up every few minutes between beeps and alarms and things that you'll have in a hospital, when you're at home, surrounded by your usual sounds, you're much more comfortable. You're less stressed. Immune system is usually a little bit healthier in those cases, and people do actually seem to live a little bit longer. And the study that came out in 2007, when they actually took those studies, folks lived on an average of 29 days longer with hospice care than without it. So it goes to show you that when people say, I'm not ready for hospice because I don't want my loved one to leave, the idea should be, well, I don't want them to leave, so I should get hospice, so they'll stick around a little bit longer.
Yeah.
Yeah.
Tough decisions.
Yes, but that's why it's such a big barrier, just the word hospice.
What kind of training do you require when somebody wants to go to work at Old Colony?
Well, one of the biggest requirements is a a well of compassion. Each one of us inside of us has this ability to give empathy and caring and this compassion. And if you don't have that in hospice care, you'll find that you're burnt out relatively quickly. Because a lot of the times the patients that we do take care of are in such crises that they're not able to be thankful or appreciative. And when you don't get that back from patients or families sometimes, it can really wear on you as a caregiver. So compassion is a really, really big part of it. And the rest of the stuff, all the medical training through nursing and social work and chaplaincy and certified home health aides, those are all the things that you can learn through training. But when it comes down to it and providing care in the hospice community, it's the compassion that really is something that you have to have within you when you come in.
I see. There's a word that I just learned in doing my research, and that's palliative care.
Sure. Yep.
What is the difference between hospice and palliative care?
Right. So even when we have healthcare providers that come in to work with us and they haven't seen palliative care before, there's a lot of education that we even need to do there. So when you think about healthcare as a general industry, there's aggressive care and then there's palliative care. So aggressive care is getting treatments, getting surgeries, those types of things. And palliative care is the idea of, well, how do we treat the symptoms and the pain and manage those types of things? So palliative care is really the notion of taking care of pain and symptom management. Now, in the healthcare environment, you'll want to always have aggressive care with palliative care. And hospice care is always going to be just tucked away in the palliative care part of it, because we're not doing anything aggressive when someone's getting hospice. But the palliative care consults that we provide at Old Colony Hospice are something that can happen well before somebody gets onto hospice. But it addresses all of those things that we look at in hospice, which is what's going on physically, what's going on socially within the family, do they need any spiritual help at this point? And it's done as a consult. So it's more like a house call from the doctors that we used to get in the old days. The nurse practitioner will come out and take a look at what's happening with your particular disease, whether it's a congestive heart failure or COPD, some different types of cancers. Even if someone's not going away anytime soon, the nurse practitioners can come out and actually talk about what might happen next in your disease. So instead of hitting 911 when that happens, they're prepared and they're able to stay home and not get swooped into the hospital system where, again, like I said, you're subject to getting infections. Maybe they try a different type of thing that you're not available for. So there's lots of things that can happen when you don't know what's going to happen next. And a lot of what we do in palliative care is educating the patients and the families as to what's going to happen next, so we don't panic. And we can really focus on the pain and the symptom and keeping it at bay, even when someone's not going to pass for any time soon.
It's sad when you think about hospital care and you got to worry about germs in the hospital floating around and affecting you in a negative way.
Right. I mean, it's a great service that we have for the hospitals and things like that, but when we're talking about the majority of folks who are towards the end of their life, they're more susceptible to be picking up those diseases and germs and really making a bad situation worse. Where if we're able to have them not panic through education, or being able, in the hospice side of things, being able to come out at 1 in the morning, because that's what we can do with hospice care that palliative we can't, is we can come out at 1 in the morning and help them through a symptom. Where with the palliative care, it really is kind of just a doctor's or nurse practitioner visit, kind of Monday through Friday, 9 to 5. It's non-emergent. But hospice, we're able to come out at any point of the day, 1 o'clock in the morning on New Year's if someone needs us.
You don't have anybody there 24 hours a day.
For palliative care?
For care in the hospice care in the residence. Is somebody on duty 24 hours a day or as needed?
So when someone comes on to hospice, they have access to the hospice team 24 hours a day, 7 days a week. We do not physically stay in their homes, wherever they are, but when they need us, we're there, we're available 24 hours a day.
Contact
and
number.
Yeah, so typically someone will call and say, oh, listen, my mom's having this bit of pain, and this is what's going on. And the nurse on the phone will say, well, give them this medication, and we'll be out in 40 minutes to see how it's going. And then we'll go ahead and visit the patient at that time, even if it's, like I said, 2 in the morning and on a Sunday.
How long has hospice been in existence?
So hospice has been around in England and then in the United States since the 70s. It wasn't reimbursable through Medicare until the early 80s, about 81, 82.
Okay.
And Old Colony Hospice was one of actually the first pilot programs in Massachusetts. So we've actually been around since 1979, which is prior to its reimbursable status through Medicare by a few years. So our founder, Dr. Ruth McLean, actually birthed Old Colony Hospice in 1979. She's still our medical director to this day. So she's been around for a real long time. And in the grand scheme of healthcare, it's really kind of a young area that we're in, but people year over year are starting to learn that it's an invaluable part of the healthcare system.
Is it a town function, town-wide function, or is it independent?
Initially, in the early stages, it was just kind of town municipalities had kind of their own visiting nurses and sometimes hospices.
Yeah, Stoughton has that.
Right, yeah, they had their own Stoughton VNA, and they do a great job. They don't have a hospice component, so sometimes if they have a patient who needs hospice services, they'll actually give us a call and let them know this person's ready for hospice services. So that happens. But as things have progressed, a lot of people don't know that there's actually over 80 hospice agencies in Massachusetts alone. So there's a lot of different agencies out there. Some of them are small and just deal with a certain municipality, and some of them are actually big corporations that are traded on, their stocks are traded. So people nowadays, especially in Massachusetts, need to do a little bit of homework when selecting their hospice, because there are differences within some of the hospices.
How many different areas do you cover?
We cover about 50 cities and towns.
So you
right
have
now.
a pretty big staff.
Yeah. Well, I mean, we've got a staff of 106, I think, employees right now. And we usually cater to about 200 patients for the hospice side of things, and about 150 palliative care patients at any given day.
Wow.
Yeah, so it's a lot of work, and we go from really up and down 495, and then out to the south of Boston, all the way out to Plymouth. Yeah.
Is there a cost for the services of Old Colony Hospice?
Anybody who ever uses Old Colony Hospice or our palliative care, there's absolutely no cost. Everything is covered through Medicare. So Medicare, when they designed that benefit back in the 80s, they said, well, if someone's going to be putting this much money into Medicare when they need that care towards the end of life, we want to make sure that there's no out-of-pocket expense. So the typical Medicare coverage is about an 80% coverage with a 20% copay. When people come on to hospice, we cover everything at 100%. So no matter what they need, whether it's one of those electric hospice beds, air mattresses, walkers, wheelchairs, medications. I mean, there's some medications out there, some of those patches, they're $150, and we replace them every 3 days.
Wow.
But we pick up the cost. And that's the mission of making sure people are comfortable, and part of that is they're financially comfortable as well. And we even have patients who we provide free care because they either haven't qualified for insurance because we don't have universal health care, and sometimes we'll have people on and we're just providing free care for them.
That was going to be my next question.
Right.
What if they don't have Medicare?
Right, so we'll actually help them out with that. We provide free care. Because we're a not-for-profit hospice, we don't have to pay out any investors or anything like that. So all the money that we get from reimbursement through Medicare, through Mass Health, through other insurances, even donations, goes back to patient care and programs, 100% of it. None of it goes to a big board or investment firm or hedge fund. Our leadership board that we do have are all volunteers. And
so there's nobody in there making $200,000 a year running the show?
No, we don't. Like I said, our board, we have about between 12 and 15 board members, and some of them are from financial sectors, from healthcare sectors, not-for-profit wings, and they really help to guide us so that we don't make any big mistakes, but also just keep us on our toes and realistic about what to expect to come.
On a volunteer basis?
Yeah, all
That's,
volunteers.
that's different.
Yeah, well, a lot of not-for-profits will have that.
Oh.
Where some of the some of the for-profit sector might just have an investment firm that says, well, what's the return? Where's our money? We need to pay back our investors. We don't have to deal with that, so we put everything that we get back into patient care and program.
That's nice.
Yeah, that's why it's important for people in the community to ask those questions. Is that hospice a not-for-profit hospice? What are the staffing ratios for their workers? Because sometimes when you run into maybe a for-profit, their staffing ratios aren't as ideal. Where we like to keep ours nice and low, so each patient gets the most amount of possible time they can with their nurses and social workers and chaplains.
That's good.
Yeah.
One of the things we hear a lot about these days when you're watching the news or reading the papers is opioid, the epidemic that's going on.
Sure.
And is there a use for, do you folks use opioids, morphine, to help treat the end-of-life situation?
There's such a, it's a really big barrier when we're talking with families and we start to mention the word morphine, because so many people assume that morphine means someone's going to be addicted to something, and also they're going to overdose on it. But when we're talking about the use of morphine or opioids, as we hear the opioid epidemic, it really is statistically insignificant that anyone becomes addicted or overdose.
At this point, what difference does it make?
Well, because when you think about when people overdose, they're taking a huge amount of these things without the guidance of a trained medical professional. And
are they taking their own medication?
People who are addicted are doing these things to just get high, and yeah, sometimes they do. But when we're talking about end-of-life care, we start low and go slow. Mm-hmm. So the initial side effects of what's called respiratory suppression don't even calculate into the math, because once somebody's had that little bit of dosage, their body becomes accustomed to it, mm-hmm. and there's no real threat of overdose or addiction. Because addiction, when you think about addiction, it really is you're doing things to get a medication or a drug, and you're doing things that are detrimental to your own health or financial well-being or society. Okay, you're doing something negative. What we don't want to confuse addiction with is this thing called dependence. And with things like opioids, if you're taking them over a course of time, your body becomes dependent mm-hmm. on them, meaning that if you take them away abruptly, you will go through symptoms of withdrawal. Mm-hmm. Now, typically when someone's addicted, those symptoms of withdrawal will trigger them to do things that are bad. But when we're talking about people in end-of-life care, we don't see a lot of 87-year-old grandmas sticking up the 7-Eleven or going to CVS and saying, give me your OxyContin. It's because they're using it for the proper things, and we are raising the levels of those medications slowly so that they can adjust with them. And if we ever needed to take them off, we would taper them off so it wouldn't be an abrupt stop and have them have those feelings of withdrawal. So that's all that is addiction is the same thing as dependence. It's just dependence turns into addiction when people do negative things to acquire those medications.
Why would you take them off of an opioid treatment?
Typically we don't.
It's the end of life.
Exactly. So a lot of times
making it tolerable.
Yep. And that's what happens. And so some people will say, well, now why are you giving mom more morphine? It's because of this thing called tolerance, where as you continue to give somebody the same amount of medication, the body becomes tolerant to it. And eventually what you need to do is give more of that same medication to elicit the same effect that you got at the first dose. And sometimes now you're giving them larger doses, which if you had started at that dose, you might risk having someone have an overdose. But because they've acclimated to it, there's really no risk. And if anyone out there thinks that there is, it just doesn't happen. When we're talking about hospice, end-of-life care, there is no risk of overdose or addiction for that matter.
Yeah, I was going to ask you, are there any instances where hospice patients can overdose? I mean, the only way I can think that would happen is if they were alone without the person there to oversee them, and they have access to their medication.
Yeah, they would have to take all their medication, hoard it, and take it all at once, which, like I said, typically just doesn't happen because we're focusing on comfort, quality of life, and when the hospice team and we're educating the family, we're all on the same page on how that goes, and we're always there 100% of the time to support them, whether it's on the phone or face-to-face.
Why is it important to choose your hospice carefully? I would assume that if you're talking hospice, that all hospices are created equal.
Right.
Or are there some that you got to watch out for? I mean, there's got to be track records of each facility.
Sure. Well, I mean, even across the nation, there's differences on what people perceive hospice to do, and there are some hospices that will just do the minimum required to keep their license in place, and there are some that will actually do above and beyond. So a lot of times we want to ask for those things because when I went to school in Connecticut, some people would call me later and say, "Oh, Mike, you're in hospice. We need Old Colony Hospice down here in Connecticut." And I said, "Well, listen, we don't go to Connecticut, but when you call around the other hospices, ask them if they're non-for-profit, because that means all the money's going back into the patients and programs. And then also ask what the staffing ratios are for the nurses."
So not-for-profit is important.
It is. I mean, that means that everything's going into patient care and programs. So they have more money to get those extra things. They're also more apt to be doing things like free care and getting the little bit of extras. And then the other thing would be the staffing ratios, because if you've got more money going into the programs, you're more able to allow each nurse to have more time with each patient. And every year we look at that, and the auditors that we have come in, and they tell us, "You guys should have your nurses seeing more patients." And we say, "No, we want them to have that extra bit of time to form those relationships, make sure that the patient and the family are comfortable with what's happening."
Right.
So they don't press 911 in the middle of the night, so that they call us and we can come out and make sure that they're comfortable.
So what are some of the questions that you would ask of an agency?
Well, so the ratios is a big one.
What's a good number for ratios?
I mean, we like to keep ours right around 13 patients to each nurse.
Okay.
Right, and there's other agencies that'll have in the 20s. So that's a big.
So you get a little less care from the ones that have the 20 ratio.
Yeah, you do, and that's just it's just arithmetic.
Yeah.
I mean, and it just allows people to do the extra work. You also want to ask if somebody in your family has Alzheimer's or other progressive diseases, neurological diseases, if they have specialized programs for that. So we do have a dementia program that's specific for any of our patients who have Alzheimer's or other dementias.
Okay.
So those are also questions.
Do you have to use the hospice that your doctor is affiliated with, or actually that would be a good thing to do because there's a history and they all follow it?
Sure. Well, yeah, like I said, you always want to get somebody that's right for you. So if their doctor's affiliated with a hospice that doesn't have a dementia program, but your loved one has advanced stage of Alzheimer's, you'll probably want to go with a hospice that has one of those programs. And under the laws, you don't have to go with the ones that are in those systems.
Okay.
And you can still keep your doctor, and they would still follow you with whatever hospice you chose. So that's a misnomer sometimes, because sometimes they'll say, "Oh yeah, we already have this hospice," and that's fine. But you want to make sure, because we really only have one chance at getting this right,
Sure.
and making sure someone has a real good experience towards that end of life journey. So we don't want to have to do you don't have a redo. So you want to get it right the first time. And so that's why it's really, really important to find the hospice that's right for your loved one. And some of those things do go into it, like what extra programs do they have? Do they have volunteers? Those types of things.
So in the case of getting the hospice program going in your house, you're actually telling the patient, or they understand that this is the end and we're going to try to make it as painless as possible. I mean, you're not lying to them. You're not saying, "Oh, we're going to take care of you. You're going to last forever."
No, I mean, typically that conversation happens either with the doctor, or we've had an informational session before we've actually brought them on, where they are actually able to ask those questions. And a big bulk of what we do with our patients and their families is to educate them and have those real serious conversations around, this is a terminal illness. Typically, this is what happens moving forward. And so that way, when those things happen, it's less of a surprise. And when things are less of a surprise, there's less panicking, and people don't unnecessarily go out to the hospital. And so what that allows for is, when people aren't panicking and we're not taking unnecessary trips to the hospital, and we have those extra 29 days, those opportunities are for someone to have those important conversations that happen towards the end of life, which are, I love you, I'll miss you, I forgive you, do you forgive me? It's all those real important closure conversations that can happen. And maybe even there's a conversation that happens around, what's the combination to the safe? Or, where'd you bury the shoebox with all the money?
What's the password?
Yeah, I know. So there's lots of those conversations that if you're constantly in and out of the hospital, you're not able to really have those wonderful conversations that come up.
Excellent. Listen, I've got a whole bunch of topics that I want to hopefully be able to cover with you for the next part of the show, but I think at this point we're going to take a short break and take a look at some of the sponsors that we have for the Community Forum show. Hi, this is Roy Cohen. The crew would like to thank Maxie's Delicatessen, located at 117 Sharon Street in Stoughton. You can reach them by calling 781-341-1662. The American Cancer Society is looking for volunteers to drive cancer patients to and from treatments. You can volunteer by calling 1-800-ACS-6662 or online at www.cancer.org. Ilsa Mock's Food Pantry and St. Anthony's Free Market is located at 2 Park Avenue in Stoughton. For more information, call Christine Gallagher at 781-341-0611 or 781-341-0549. To get involved with Meals on Wheels, call Jessica at 781-344-8882, extension 2. The Stoughton Penny Saver. Our business is advertising your business in Stoughton. To advertise, call 781-344-4833. Community Forum showtimes here in Stoughton. You can see it on Thursdays, Fridays, Saturdays, and Sundays at 6 p.m., Monday at 8 p.m., Tuesday at 5 p.m., either on Comcast Channel 9 or Verizon Channel 28. If you have any comments or suggestions, contact us at communityforum1@yahoo.com. Samaritans, 41 West Street, 4th floor in Boston, Massachusetts, 02111, or call them at 617-536-2460. The 24-hour helplines, 877-870-HOPE or 877-870-4673. Samaritans, 800-252-TEEN or 800-252-8336, or online www.samaritans.hope.org. For you bingo players, I want to tell you about the Monday Night Bingo being held at the Ahava Torah Congregation, 1179 Central Street in Stoughton. The doors open at 4:30 p.m. The games start at 6:30 p.m. You come on down and win some money. They have 2 big prizes. One is $1,199 and the other one is up to $3,000. So come on down. Okay, we're back. I'm Roy Cohen, and I'm hosting today's show with Michael Cruza. He's the Director of Business Development at the Old Colony Hospice and Palliative Care. They're located at 321 Manley Street in West Bridgewater, Mass. And you see their information up there. Email, if you want to get in touch with Mike, is mcruza@oldcolonyhospice.com, or on the web, www.oldcolonyhospice.org. I went on to it, and there's an awful lot of very valuable information. You can learn about the Old Colony Hospice, and please do it. I have some other areas to explore with you, Mike.
Sure.
I noticed that you have several other options that people can find out about. You have a veteran program. Can you tell us something about that?
Yeah, we really take our veterans and their past really seriously, in that we want to make sure that we celebrate their service. So a lot of times when we do have somebody on hospice who is a veteran, we are going to make sure that we honor that. For a lot of people, it's been years, if not decades, since they served, and to allow family members as well as the patients who sometimes don't like to sometimes go back there, it allows them an opportunity to say, yeah, you know what, I put myself out there, I put myself at risk, I served my country. And to acknowledge that is an amazing thing. So a lot of times what we'll do is we'll have a certificate that's framed, we'll have that for them. We have them what's called a care blanket that has the emblem of their branch of service for them. And then we also will do pinnings, where we do a whole ceremony to acknowledge their service. Because like I said, so many times, children and the grandkids too don't know that somebody served. And even for me, when my father was going through all of this, so many family members, extended and friends as well, had no idea that my father was in the Air Force. It's because he did it when he was young, and he's old now.
Didn't want to talk about it.
Well, it usually didn't come up. It was just so far removed. But people were just astonished that he was actually in the Air Force. And I said, oh yeah, of course. How could you not have known that?
Yeah. I understand, when you think of hospice, you think of treatment being done in the house,
right,
in their patient's home. But you tell me that there's a way to treat homeless?
Yes. I mean, whenever somebody needs hospice care, where they live should not be a barrier. So we see patients who are in hospitals, we see them in assisted livings, we see them in their residential homes, we see them in nursing homes, we see them in independent living, we see them in apartments. We even see patients, as long as it's safe, who are homeless. And we've done that before. So sometimes we have to meet up at the Dunkin' Donuts, or we meet them up at the smoke shop, or wherever they call home, and we will do their vitals there, and we will give them their medications that they need. And as long as that's a safe way for them to be, that's fine. In this one particular case that I remember, eventually he didn't show up at the Dunkin' Donuts. And after a few hours of searching to the area hospitals, he ended up in the hospital because someone found him unresponsive. And so after treating him in the community, homeless, for a couple months, we ended up getting him into a nursing home where he stayed for about 3-4 weeks and then passed comfortably under our care at the nursing home.
Tell us about the volunteer program that you folks have.
Sure. Well, I mean, part of hospice is a lot of people, once we've cared for someone they live to give back. So we have a lot of volunteers from a lot of varying backgrounds that have a lot of different talents. So we have a good chunk of our volunteers that are just for social visits, because a lot of the patients don't have a lot of family, or they don't have a lot of friends that are able to visit them because they're also infirmed or not able to get out. So we have volunteers that can sit with them and be companions. But we also have volunteers that can do other things. So we have pet therapy volunteers, so they can bring pets in so people can have that type of enjoyment. Volunteers that do Reiki, which is another type of therapy. Volunteers that are veteran volunteers, where we will line up a veteran volunteer with a patient who is also a veteran. So if they want to talk about their days in the service, they can. So it gives them that extra layer of a perspective. We have other volunteers that can do different types of massage. They can do different types of modalities, therapies, hand massages, those types of things. All the extra little bits of comfort that you like to have when you're not able to go out and get it, volunteers can really provide it.
Interesting. There's a couple of things that I saw when I was looking up your information, that the Old Colony Hospice is a Hospice Honors Elite winner for 2 years running.
Yeah.
Under your guidance.
Yeah. Well, it's obviously a team effort.
Yeah.
But each hospice has to work with an independent survey group, and that survey group, is not beholden by anybody, and they send the surveys out to the family after someone has passed, and they ask them a series of 24 questions about how everything went with their hospice experience. Now, of those 24 questions, if they answer above the national average on 20 of the 24, that hospice is considered Hospice Honors. But if the family answers favorably above the national average on all 24, 100% of those questions, you get the designation of Hospice Honors Elite. And we were actually the only Hospice Honors Elite recipient in Massachusetts this year.
Wow.
And only one of 2 last year.
Congratulations.
So yeah, so that's a great thing to have, because it's from the perspective of the family. And those are the folks who really, aside from the patient, get those extra benefits from hospice. And so to have that feedback come in so favorably, it is an absolute just pat on the back that we get from the families.
That's nice.
Yeah.
And I guess one of the things that to follow that up is your organization is one of Boston Globe's top places to work for 2 years in a row.
2 years running.
So it kind of follows up. You get happy people working, you get happy people getting the awards.
Right, and so like I said, the elite status is from the caregiver's perspective, and now this is the employees of Old Colony Hospice, myself included, saying that yeah, we know we're providing a great service, but we love what we do. Because we're allowed to take the time that we need to make sure we're doing our jobs properly, but also providing an excellent work-life balance for our employees. Because like I mentioned at the beginning, the amount of compassion that you need to give out on a daily basis as someone who's caring for these patients is tremendous. And to not support the staff by allowing them outlets to talk about what's been happening with their patients, also allow them to have vacation time, to recoup and regenerate, are amazing things that you can do for employees. And it turns out we're doing a pretty good job, because the surveys would say, according to the Boston Globe, that we are doing a good job. We were actually the only hospice on the entire list. In last year, we were in only the small business, and we were number 5 amongst all small business. And then this previous year, we were actually number 11, but because we were getting bigger, we're actually considered a medium-sized business.
Excellent.
So it's a really good thing to be able to be acknowledged from caregivers, but then also the employees who are working with those caregivers.
Good. Congratulations.
Thank you.
All this since 1979.
Right.
Amazing. All right, I got a whole bunch of quick response questions for you. Tell us about the Old Colony Hospice Walk.
Right, so every year we talked about that we take all the monies that we get from Medicare, but it's also donations. So our walk we have annually, and that is another one of our revenue builders, where we, everyone is on a team and we try to raise some funds, and those extra funds go to things like with some of our dementia program, that goes back to getting music and CD players for people who need music therapy. So it's something like that. But then it's also some of those free care recipients that needs to be paid for too. So we get a lot of those extra things from doing things like the walk, and it's a wonderful event. It's a big memorial walk. So a lot of times we'll have family members from patients that we've taken care of. They'll all get together, probably do up T-shirts that have their loved one's favorite saying or a picture, and they'll walk in memoriam for their loved one, which is an amazing thing to be able to do.
And if anybody wants to put on a walk, they can get in touch with you and
Absolutely.
you tell them exactly what to do.
Yeah, it's really a lot of fun.
What about inpatient hospice facilities in Massachusetts?
So go ahead.
No, I'm just wondering, are there any?
Yes, there are a few. There's not too many.
So basically all treatment is in the house? patient's home.
Yeah, and there are some hospice houses. Sometimes we'll have to send them out to some other places. But by and large, 99% of the patients who need hospice get it where they already reside.
Okay. And we've already answered this basically, but the question I have, which we may ask again, is hospice free in Massachusetts?
Yeah, I mean, for anybody who needs it, it's free. I mean, and I don't think I went through everything that it does provide, but it covers all those medications. It covers all of the equipment that's needed. It provides for the nursing care, the social work care, the chaplaincy, the home health aid, and all of the extra thing that happens even behind the scenes. So the billing that's done on the behalf of people, and then there's the volunteer coordinators who coordinate the volunteers that come out. So there's a lot of things that happen behind the scenes that a lot of people don't know about, and it's those extra people that are behind the scenes, and also the people who are in the trenches, with the patients doing the good work, that completely make up that entire hospice team.
I don't mean to be repetitive, but I'm going to, since I'm being the host.
Sure.
The questions I'm about to ask is pretty much answered by the awards that you've accumulated in the last couple of years. But why choose Old Colony Hospice to provide your care? I mean, a reminder is okay.
Well, I mean, obviously the awards would show you that we do a good job. But we also have, all of our nurses are from within the local area. I mean, everybody that we employ lives in that territory. So there are other places where people are coming from other parts of the area because they have larger swaths of territory to cover. There are some places that cover even all of New England. But we really cover just the South Shore area because we've been doing it since 1979. But all the folks that work for us are all local people, and they're able to, when we're working with patients and someone says that, I need, my grandson is going to play down at Legion Field, most of the social workers or the nurses that know the Bridgewater area will know exactly where that is. So it gives that extra layer of comfort and trust that I think is very, very important when you're helping somebody who is in a compromised situation with the disease process.
Okay, this paragraph I'm just going to read because I want to do it.
Sure.
Since 1979, Old Colony Hospice has been helping patients and families through our comprehensive approach to exceptional hospice care. We've heard the reasons why. We have the Community Health Accreditation Partner Seal of Approval. We didn't talk about that.
No. So what that means is, in order to be a duly certified hospice, you need to abide by the Medicare rules and regulations. Now, so that's a minimum set of benchmarks that you need to meet. With the Community Health Accreditation Partnership, you need to even get a higher benchmark, and they come out and really put your feet to the fire as far as making sure that you're meeting above and beyond the Medicare regulations. So every few years, we need to go through that survey process where they come in and they look at all of our documentation. They ask questions of patients and families, and even do ride-alongs with our staff to make sure that we are providing the absolute best possible care around.
You're exceeding the standards of care set by Medicare. You've been named a Hospice Honors Elite recipient by Data Analytics Center.
Right, that's that Hospice Elite status, yes.
Okay, it recognizes hospices that provide the highest level of quality as measured from the caregiver's point of view. And they also offer many specialized programs and services to our patients and their families, as we understand each patient and situation is unique.
Right, and like I mentioned about the
That's nice.
About our dementia program. So we have a dementia program called the Forget Me Not program, because so many of our patients they might not be essentially late stage Alzheimer's or things like that. They may have an earlier stage, but they're on hospice for cardiac disease or a respiratory disease. But we might have them under our care. So we understand that there's a different needs of a lot of our Alzheimer's patients, and there's different things that we could be doing outside of increasing medications there are things that we can do with music therapy that will help to soothe them. So if we can get, and I'm a big believer in this, music that is particularly important to a particular patient, a lot of times it can get them out of that tough spot that they're having where they're confused or overwhelmed or frustrated. Bringing somebody their own music that's important to them can many times get them to a part of their brain that's still there, that they experienced really good times, really good relationships, and can help them get to a positive point and allow them to kind of stay in that moment.
I think I've heard recently that there might be some medication available or coming up that's going to help people that have the dementia.
They're constantly doing new trials. There was a recent one out of that Biogen was working with.
Right, they were a local company.
Yes,
in
yeah,
Cambridge.
A lot of them are doing some really, really excellent things. I think that it's kind of fizzled out in their recent trials, but I've recently sat in with the Alzheimer's Association, and there's constantly different trials and medications that are going through different levels of trials in the lab, but then also human trials, which is great that they've got this much more funding and this much more of a focus on getting to that point, because Alzheimer's and those related dementias are amongst some of the worst things that happen, where people are no longer recognized by their loved ones. And you know, I've talked a little bit about my dad, how he passed, and we dealt with that, but his mother, so my grandmother, had dementia, Alzheimer's. And there was a point where my grandmother called me Joe, which was my dad's name, because in her brain, her son was a young guy. And so at that point, my dad must have had some feelings of grief and loss, and my mother no longer recognizes me. And so in hospice care, through our social work and chaplaincy, we're able to tackle a lot of those emotions that happen with family when those things do come up, and we do it at an appropriate time, which sometimes can happen well before someone passes away. We're dealing with feelings of grief and loss with family members. So it's great that our staff is able to tackle those emotions at that time.
In the last couple of minutes, when is the right time to ask about hospice?
Oh, that's a really good question. So each disease process has kind of different hallmarks. But once people are starting to go back and forth and be frequent flyers to the hospital, that could be a sign. Because when we're starting to have recurrent infections, it means there's something going on with our immune system that's not allowing us to fight off these diseases. So something might be afoot there. Another thing to look for is unexplained weight loss. So there might be a disease process that's happening that's not allowing someone to absorb nutrients. So a lot of times we'll see that with some of our dementia patients. They'll start to lose weight, and that's because the disease process even affects the ability to absorb food. So there's a lot of things that happen when someone experiences weight loss. Other things are people are just, they're sleeping more often, the appetite is low, and then even sometimes when we're not able to have good appetite, we're not able to absorb our nutrients, sometimes people will get wounds, you know, on their bottoms or on bony parts of their body. And those are also signs that the body's starting to not be as effective.
Hospital care, how does it begin?
Oh, hospice care?
Yeah.
Oh, so initially when someone needs us, we will sit with them and explain the whole benefit.
Okay.
And allow them to understand, you know, what it means to have hospice care, which that's the great part of the conversation where you're able to dispel a lot of those myths around it doesn't mean you're dying tomorrow. So we'll talk to them. It's 4 or 5 pieces of paper that they sign. And the good news about hospice is that if you come onto hospice on Monday and and all of a sudden there's a cure for your particular disease on Tuesday, you can come off on Wednesday. And it doesn't prohibit you from coming back on if you get another disease on Thursday. So it really is a fluid type of service that you can kind of come on and off if you're feeling better or worse.
Okay, quick answer, how often a visit's made?
As needed. So whenever sometimes we see patients every single day, and sometimes we see them twice a week.
And it's available after hours?
Absolutely, round the clock. We have, because we have so many home care patients, aside from even patients in nursing homes, we have sometimes 3 or 4 staff after hours and through the weekends too.
Mm-hmm. And never a fee for hospice services.
Never a single. We have never sent a bill out
That's amazing.
to a patient or family.
That's amazing.
Yeah.
And you have a program for dementia patients?
Right. Like I mentioned, that the Forget Me Not program is specifically designed to make sure that we're doing the most we possibly can do. So through music therapy, through what's called a compassionate touch, as well as what's called weighted blankets, where we're able to kind of soothe that central nervous system by providing a weighted blanket. It kind of acts as like a portable hug, which is another kind of amazing thing that we're able to provide. That again, it's not an increase of medication, but it's something else we can do outside of the medications.
Okay, is it possible to put up the slide with his information on it again? There we go. Old Colony Hospice and Palliative Care. They're located at 321 Manley Street, West Bridgewater, Massachusetts. You can send an email to Mike at mcruza@oldcolonyhospice.com, or check them out on the web at www.oldcolonyhospice.organization, or call them 781-341-4145. But I suggest you take a look at their website. It's full of great information.
Mm-hmm.
Michael, I thank you very much for a very informative hour.
Absolutely a pleasure.
And I appreciate you coming in. And at this time, I'd like to thank Mike Hammond, Jeff Pickett, C.J. Mullen, Dave Young, Gina Coe, especially my button pusher there, her daughter Bella, and Leo McGowan. We're hoping that you're going to be back here soon. We miss you. And I think that's it for today. And Roy Cohen saying thank you very much for watching the show, and we hope to see you again real soon. Bye-bye.